and welcome to the webinar, Overview of Implant Placement and Restoration. The lecture will be presented by Tremaine Watkins, CDT. And with that, I would like to introduce you Tremaine Watkins, CDT, Director of Strategic Education for National Dentex. Tremaine Watkins has been working in the dental laboratory industry for more than 30 years. After graduating with a Bachelor of Arts from Trinity College in Issaquah, Washington as class valedictorian, he has gained extensive experience in all aspects of fixed and removable restorations with an emphasis of implant-supported and retained restorations. He also has provided clinical support for case planning, troubleshooting, and implant placement. He has trained other technicians in all aspects of dental technician and has written and lectured on several aspects of restorative dentistry. Tremaine, take it over.
All right. Well, thank you for the kind introduction, Nicole. And thank you to everybody for joining in. As you guys know, one of the most difficult things about talking about implants is figuring out what you're going to say. I mean, we've all been to courses that go for 2 days covering stuff like that. So I was like, well, how do I bring the scope down enough? And so what I'm going to be focusing on tonight is single tooth crown and bridge type restorations. I have a couple slides at the end that will go over a basic all-on-X workflow in case you have a patient who kind of comes into your practice or something like that. But be looking for other opportunities from IndieX Education to cover that, because that's a big topic in and of itself. With a lot of these processes, I try to go into kind of medium depth, not all the way into the nitty gritty and pick up this instrument and do that, but not so much of an overview that you don't really gain any nuggets. I kind of feel like most people who participate tonight are going to see, I'm hoping, a few good things. There's probably going to be some things you already know. Apologize for that. But I think you'll get some stuff that will really help you in your practice. So again, thanks for joining in, and here we go. So I have a little bit of housekeeping I have to do myself. I am a full-time employee of National Dentex Corporation, and I've received payment, financial support relating to creating the contents of this presentation. However, I don't have any commercial support. In other words, no companies have paid for this. So this is just my opinion for what it's worth in terms of products and stuff that are mentioned. All right, so let's get into it. Like we were talking about, dental implants are a very large topic. Right now, there's 120 million people in the US that are missing at least one tooth, and we expect that number to grow to at least 200 million in the next 15 years. However, even of that group, only 15 million have been treated with a bridge and 3 million with implants. So that means there's a market of 100 million patients who could use an implant. So that's probably enough to keep everybody on here busy for a long, long time. So I guess the point of that is that this is a relevant topic, and everybody can probably place and restore more implants than they're doing right now. I love history, and I used to have a really big slide on this, but I've kind of cut it down a little bit. But one of the interesting things you find when you look at archaeology from a dental perspective is that ever since there's been people being formally buried, having teeth was considered a cool thing. Now, a lot of the ancient cultures, it looks like a lot of the so you might say implants that they placed were more post-mortem, but nonetheless, it's interesting that replacing missing teeth is not a new idea. It's been around for, the picture on the right is of a bamboo pig hammered into someone's skull in ancient China. This is 4,000 years old or so. And then on the left, I'm sure many of you have seen the blade implants. Like I said, I kind of progressed through the whole thing, but I feel like this is the last odd implant before we got into root form implants. And modern root form implants started with the work of Dr. Per Ingvar Brånemark. He was a Swedish orthopedic surgeon. For whatever reason, he was studying blood flow in rabbit femurs, and he placed pure titanium inserts in the blood vessels to keep them open, basically. When he went to remove the titanium inserts, he found that the bone had formed a biological attachment. And if he broke the bone, it broke bone to bone. It didn't break at the titanium cylinder. So he called that direct attachment of living bone cells to titanium osseointegration, obviously a term we still use today. In 1978, he released the first two-stage threaded implant made of pure titanium. And interestingly, he's also the first to develop the zygomatic implant in the 1990s. So a lot of this other ancient history, there are little bits and pieces that are relevant to what we're talking about, but the implants that we're using today basically are descended from the ones that Dr. Brademar first developed in 1978. So some of this is a little bit obvious, but bear with me because there's a point to it. As we know, our natural teeth gain their function and aesthetics from the coronal segment and stability from the attachment of the root to the alveolus through the periodontal ligaments. Before dental implants, the restorative options for missing teeth like dentures, partials, and bridges could replace the coronal aspect of the tooth pretty well. What frustrates most patients who get these kind of restorations is they don't come near, with the exception of bridges, the stability of a natural tooth. And even with bridges, usually the ponics, the areas that aren't supported or aren't directly attached, let's say, to the patient, are the most irritating areas to the patient because they get food impaction under there and the like. This is why I would say, and this is what I would say to a patient, is why an implant-supported restoration is the best available replacement for a missing tooth today. As you hear out there in the implant community, implants are not teeth. Especially the shock-absorbing aspect of the periodontal ligaments is something that's obviously not present with implants and tends to put more load on our restoration. So it's better to have a natural tooth than an implant, but I would say the second best thing is dental implant. Now, why am I telling us this obvious stuff? And I think it's because it makes us more effective at our treatment presentation. Most of the time, for most of our patients, an implant-supported restoration will cost them more out of pocket than other restorations. So when we present the treatment, we need to help them understand why this treatment most likely will feel superior to them based on compared to the other options that are there for them. I mean, obviously there's biological advantages, but we can just focus on the prosthetic advantages, I would say. And at the end of the day, it's not a sales job. I mean, if we tell them what we know in our experience and they say, well, I don't want that, that's okay. Because at the end of the day, then if they're dissatisfied with the option that they've chosen, they say, man, this partial is not very stable. They think to themselves, doc told me it wouldn't be very stable. Maybe she knows what she's talking about. So, I think that I'm a big fan of really good communication. And I would say that this is an example where getting in there, putting in the time to really explain the benefits to your patient will always pay dividends, even if they don't choose that course of treatment. So we're gonna kind of follow along the life cycle of an implant, if you will. So we'll start out with placement. So one of the things we want to think about is every surface of an implant is designed to optimize its function. So when we're selecting an implant system, we want to kind of look at the whole picture. Is the surgical instrumentation easy to use? Is the prosthetic instrumentation easy? Do I like the prosthetic connection? Do these implants show favorable bone stability over time? Do these implants get good initial stability? We kind of need to think about that. Another thing that's really important that I guess I maybe see more as a dental technician is how long an implant will last. My first exposure to dental implants, a little bit in the lab, but my mom got dental implants in the early 90s, and she still has both of those. And lucky for me, they're original brand marks, so I can still get restorative components, whatever. But I'll have to tell you that one of the more frustrating things in dental laboratories is when we have a perfectly healthy implant that we can't get restorative parts for because of companies gone out of business or whatever. And so sometimes we'll tell the doctors, well, why don't you try to cut it off and save the abutment, because we're really going to be out of luck if we got to go to fixture. So just another thing to think about when you're purchasing an implant. This will probably last the rest of the patient's life. And while we don't have a crystal ball, some companies seem like they're more stable and more likely to be around making parts than others. And I think that should come into play. When we're thinking about the material from which the implant is made, we want to make sure that it's strong enough to absorb the additional loads that it'll receive because of the lack of that shock absorbing function on the periodontal ligaments. And especially you'll see some ads now for modern implants where they dip them in a vat of blood. You can watch the blood go halfway up the threads. So having them be so hemophilic really helps with blood penetration and then osteogenesis. So that's really important. Last but not least, I'm sure most of you know that when you're placing an implant, you want to get primary stability. When it's placed, it's like a wood screw. Obviously, over time, it's stabilized by the bone that adheres to it. But for that to occur, the implant has to have less than 150 microns of movement in any direction during the healing. And so the shorthand way of checking that is that you have at least 35 Newton centimeters of insertion torque or a minimum ISQ score of 55 on the day of surgery. Couple other things to think about is there are some implant systems that have the same size platform for a variety of different implant sizes, and that can be really handy for you prosthetically. And sometimes you can find ones that have different thread patterns for, say, immediate cases and dense bone cases and stuff like that, but the same instrumentation on the surgical side. So you can see that you can optimize the implant side of your practice by making sure you select an implant that helps you out. So back in the day, when we first started doing dental implants, the platform would be placed equicrestal, just like it is now, but most of the time, radiographs over time would show crestal bone resorption, sometimes as much as 0.5 millimeter a year. In the olden days, we were more like, well, if the implant stays, that's a W. So we weren't as concerned about that. Over time, people have gotten to where they don't really like seeing that gray edge above their gums when the bone resorbs. So implant manufacturers have been working hard to enhance crestal bone retention. There have been, as you know, a lot of improvements in implant materials and especially surface microtexture, something we've seen a lot of work on. But believe it or not, the biggest contributor to better crestal bone retention has been the switch to platform shifted implants. These days, most of the implants that you buy are going to be intrinsically platform shifted, but there are a few systems out there that still don't have that. And this is this is an example of no platform shift. See how the abutment is kind of flush with the surface of the implant? And this is a platform shifted implant here. You want this because I think the current studies are leaning towards keeping the bacteria in this micro gap away from the bone leads to better bone retention. Now, the next frontier in implant health, now that we've kind of gotten to where implantation is fairly predictable, is I think going to be tissue attachment to the abutment. There's a couple of implant companies that are talking about this now, and I think it's going to become a topic of greater interest in the near future. I think we're seeing both mostly advertising and anecdotal evidence at this point, but I would keep an eye on unbiased academic studies that are coming out to look at this, because I wouldn't be surprised if in the not too distant future, most of the implants we're placing, we're also putting an abutment on them early and then allowing the tissue to seal up against that. So that way we just have one more layer of protection for our implant. Obviously, when these implants were first placed in the 70s and 80s, everything was placed freehand. So usually 2D x-rays were used to analyze the local anatomy, and then there's models and photos to approximate the bone volume. So as a surgeon, doctor make a plan, preliminary plan, get some implants, different sizes that might work, and then, perform progressive drilling to get an appropriately sized osteotomy and place the implant. Many times the initial pilot, as you see in this image here, would be drilled and then the radiograph done to see how this was interacting with the surrounding structures, in this case, the adjacent roots, and then trajectory adjustments could be made. The implant would be placed equicrestal or slightly subcrestal and sutured up over a healing abutment. Most of the time you're doing two-stage surgeries in those days. And I would say freehand surgery hasn't changed that much, other than we mostly see single stage today. But one of the things I think that is a challenge with freehand surgery is that you have a lot of things you're trying to control at the same time. Because not only are you having to manage the patient and do your surgical execution, get your flap and do your osteotomy, basically go through all the technical aspects of doing surgery, you're also doing the prosthetic plan at the same time. You're setting the emergence angle, you're setting the proximal contours, you're setting the buccal contour, very importantly. And one thing that we want to keep in mind is people buy teeth, not implants. A lot of times with the implant itself, as hard as we work with that, it's at best a means to an end, and at worst a necessary evil from the patient's perspective. They want that tooth. And so we need to kind of keep in mind that from a patient perspective, if we get an awesome, well-integrated implant and a not so pretty restoration on it, that's not really a win. And we've all been in that situation, so we want to try to avoid it. Well, how do we do that? I would say that guided surgery can be a unique benefit in this area. Of course, every implant can be placed with an unguided freehand procedure. But I would say that with the advent of CBCT scanners being so prevalent, almost every implant could be placed guided as well. Of course, a freehand surgery is less costly and easier to schedule. And what are the advantages of the CBCT guided surgery? I would say that in terms of actually doing the surgery, it usually goes much quicker than a freehand because you don't usually have to do mid-process scans and the like. If you're doing a single implant or a simple case and you're confident in your guided surgery and your plan, you can do a flapless surgery. So you just use a tissue punch or a crestal incision, and then there's not near as much healing for the patient. But I would say the main advantage is the prosthetic result. So in most cases, if you look at the anatomy of the bone, there's more than one angle and position that we could place an implant and get a healthy result. So the question becomes, how do we decide which of those good positions surgically is the best position? I would say the best position is the one that creates the best prosthetic. So that's the advantage of guided surgery, is that when we do a surgical guide, the first step is we design the tooth that we're going to replace. Then, based on the dental anatomy, we place the implant in the best position possible to create the final restoration. When you get a freehand implant, you guys have all dealt with this. A lot of times you'll wind up warping the implant, the prosthetic, to kind of fit to the implant. On the other hand, when you're doing a guided surgery, the restorative phase should go much more predictably because you put the implant exactly where you want it. And if you know there are going to be prosthetic complications, you know way ahead of time, and you can start figuring out, what am I going to do with this? And we'll talk about some strategies later. As we know, osseointegration occurs because the cells have become bone or deposit on the surface of the implant by the patient's blood. Of course, this not only creates initial osseointegration, but also creates long-term implant health. So because the implants, of course, don't have blood vessels going through them, the blood needs to perfuse around the surrounding bone, and we need to leave enough space. So we try to leave 1.5 millimeters from any surrounding structures, or 1.5 millimeters of bone in the areas, and 3 millimeters between implants to allow that nice blood flow. Like you see in this image here, when we get too close, when we don't leave enough bone around, it's like we're strangling the blood supply, and we can expect to see bone loss in those areas most of the time. And this is how you kind of decide what's too big an implant. If your implant is so large that we're not having enough bone around there to really give us the good blood perfusion, then we probably should go a little bit smaller. We'll talk about the drivers for larger implants on another slide, but as in most things in dentistry, there's a tension, and we kind of want to exist in that happy spot in between. In implant placement, as you guys know, heat kills bone. The bone must be kept below 116 degrees Fahrenheit during placement, or you can have widespread bony necrosis. We want to use very sharp progressive drills. Most drills have a life on them. They'll say do 10 or whatever. So we'll want to keep track of that and replace them. And in general, it's less of a concern during guided surgery because you're running the drill so rapidly that you're not in contact with the bone for a long time to generate heat. I think this is not something that's a huge problem because we know what it is. We use irrigation, stuff like that, but it's just something to keep in mind. One other thing about implant placement that's good to know is that when you're placing an immediate implant, studies have shown that you want to have 4 threads at least into the bone apical to the extraction site to make sure that you get nice stability. This is why sometimes you wind up placing really long implants. We'll talk about why it doesn't really help from us. I'd say load resistance perspective, but sometimes we need to do it just to get into some nice sturdy bone to get us that primary stability that we need. There are a couple systemic concerns that can prevent bone regeneration and osseointegration. Years ago, it was like you had to be a 30-year-old triathlete to be considered for implant placement. Now, most people that can handle the anesthesia and the surgery are candidates, but there are still a few major contraindications. Smoking probably is the biggest. You guys know. If a person is a heavy smoker, their implants are very, very likely to fail. They need to be warned. And, they need to know if they choose to continue to smoke, they're risking the investment that they've made in those implants. And they're risking having to place another set of implants that'll be smaller and less optimal than the set that's going in now. Second, I would say is unmanaged diabetes. It's such a common metabolic disorder that we got to keep an eye on it. It can, of course, also affect osseointegration. And then osteoporosis and the bisphosphonates used to treat it for different biologic reasons also are major concerns for the bone regeneration that we need. Bisphosphonates can hang around in people's bodies for a long, long time. So we want to make sure that we're aware of that when we're doing our medical histories. As you guys know, in the maxilla, the main area we run into difficulty is the distance between the alveolar crest and the sinus floor. In the posterior, when teeth have been missing, not only do we lose bone crustally, but we also lose bone to the sinus as it gets pneumatized. In all on X, we usually try to get around that by placing an angled implant along the medial wall of the sinus. But when we're doing single tooth crown and bridge, sometimes the best way to place it is to place an implant that's perpendicular to the axis of load. And so we may need to do a direct or indirect sinus lift. The other major concern in the maxilla is bone density, especially in the maxillary posterior. We can oftentimes have D4 bone, which is not that awesome. And so we'll need to definitely use a soft bone protocol to try to get that primary stability. Now, interestingly enough, I was talking to an oral surgeon a few years ago about this, and he was saying the funny thing about spinners, he said, if you think about it, the reason that the bone is so soft is because of increased vascularity. We want to get a bunch of blood to the implants. And so he'll find sometimes he'll get an implant that's kind of a spinner and he can't put a big enough implant in to achieve stability. So he'll put a cover screw on and cover it. And he said a lot of times when he's looking at these radiographically and testing them, they can be some of his best implants once they've integrated because they have such nice blood flow. So all hope isn't lost with posterior maxillary spinners, other than, we need to bury them. It becomes more of a challenge when we're doing an immediate load type case, because obviously we're not going to want an immediate load an implant like that. In the mandible, there are more significant concerns. Everybody who's on this call is an expert in dental anatomy, so I'm not going to beat on this too much, but we need to make sure that we stay 2 millimeters away from the IAN canal, which in your radiographs will usually look like, as you know, a bright white tube running through there. And then we also want to watch out for the sublingual artery. So when we're planning implants in the posterior, depending on the patient's anatomy, we want to stay well away from that, from the mylohyoid ridge, so that we don't accidentally perforate that. Another time where guided surgery can be helpful, because then we can use the stops to help us make sure we we get in the right spot. We need to make sure our emergency protocols are set up, in case something happens. So let's talk a little bit more about implant diameter. So we talked about why we might want to undersize the implants a little bit in order to make sure we have enough bone and blood perfusion and stuff like that. So let's talk about why we want to have larger implants. Let's start by talking about very narrow implants. Almost every implant manufacturer, at least the ones I'm familiar with, has an implant that's between 2.9 and 3.1 millimeters in diameter. These are really handy in the mandibular incisor area and can also be helpful in the maxilla, depending on how the person's anatomy. But we want to keep in mind these implants, I mean, you could read the instructions on them. They're not designed for posterior teeth. They're not designed for bridges. They're designed to support only single teeth. So we need to make sure that if we're using these implants, that we're using them in the very limited indications that they're for. And then when we're looking, so let's set those aside now and let's talk about what we might call normal implants, 3.2 or bigger, basically. So let's think about our bone to implant interface. If you see an implant fail, it always fails, I mean, almost always, between the bone and the implant. So what we want to do is we want to unload that area as much as we can. If we say that at every tooth position, the maximum occlusal force is a fixed number, it's, let's pick a number, let's say it's 100. Well, if I have an implant and I increase the diameter by 50%, I've cut down on the load per surface area at that critical implant to bone interface, and I've made a better situation for my patient, less likely to get failure from overload. And you'll notice that I'm emphasizing implant diameter and not length. Strain gauge studies that have been done show that the majority of the load on an implant is at the platform. And once you get beyond 10 millimeters of length, the rest of that implant's along for the ride once it's integrated. It's not really doing anything. So it's holding the implant in place, but it's not resisting significant amount of occlusal force. So when we're trying to deal with heavy load, let's say we have a large, strong patient, we're putting molar implants in, if our option is to go wider or longer, we always want to go wider because that's going to resist that load better. The other thing is that we want to get really good emergence profiles. We've all seen the lollipop on a stick crown where we got a little tiny implant and a big old crown on it. And it is impossible to get really good hygiene on those cases, in my opinion. So we don't want that. We want to think about, can I put an implant in that is similar in size to the root of this tooth that was missing? So you can see, I like this. I won't mention the company, but they're the only ones I've seen that have put something like this together, and it shows how you use your really small implants here, the 3 millimeter ones we were talking about. You do your 3.25s, your 4s here, and this is where you use your 4, 5s, 5s, 6s, so that not only is there more load there, but we also get that nice emergence profile so our crown looks kind of tulip-shaped. Especially in the aesthetic zone, the tissue shape above the implant is going to be really important in the overall hygiene and aesthetics of our case. Now, you guys know that with a couple exceptions, most of the healing abutments that are out there are a cylinder, and there aren't that many teeth that have a cylindrical root form. So oftentimes we're going to have a mismatch between the emergence profile of our crown that we made and the emergence profile of the tooth it's replacing. So back in the day, and I've done a few of these, but they're not that popular. We used to make custom healing abutments like this. You take a temporary cylinder. So you take the model where you were planning on putting the implant, you shape up the model and then build some composite or whatever, acrylic. So you had a nice emergence profile on a temp cylinder, polish it all up, and it looks like this. A lot of work and it's not super pretty, but it'll usually get you a nice emergence profile. But that's not the end of the story. So then when you go to take an analog impression, you have to alter your impression coping to be exactly the same shape as that. Then in the laboratory, we have to make sure that we make our soft tissue model well, and that then our abutment fills in that whole space. So there's just a lot of opportunities for things to go wrong. And for any of you that have done that cup technique for making a custom impression post, it's a pain in the behind. Now, I would say digital impressions have made the clinical side of this a lot better, because now you can just take this baby out, scan really quick before the tissue collapses, and then your scan body doesn't really need to capture the tissue. It just captures rotation and stuff. We'll talk about that in a minute. But it's still not very fun and cool looking, and not very cool looking. So there's a company that makes these machine custom healing abutments, and I don't see a lot of these being done, and I think it's something that could be a real benefit. So the way you do this is, at the time of surgery, your surgeon will take a scan of the implant position while the tissue is reflected, and then put a cover screw, suture it, send it in. Then we'll design an ideal emergence profile, and have the abutment milled, the healing abutment, this one, and then send it back, and it's placed in second stage surgery. The cool thing about this is that when you get the case restoratively, what you do is you just take a scan of this. We already have this file, and then it's possible to make an abutment that has this exact same subgingival profile, but a normal abutment on the top. Note that you can put a screw hole through the crown, so this workflow will work for a cement or a screw retained crown. And that way you get a much more predictable insertion, because you've created the tissue shape with this, and then you made the exact same profile with this. So it's something that's kind of cool that I think we could use more of in the right situation, especially in the aesthetic zone. So let's talk about provisionalization. Again, why are people buying these implants? Because they want teeth. So they're going to want us to come up with something that we can let them wear for the 2 to 6 months when the implants are healing. There are quite a few options these days, and I just want to talk about them really quick. Flippers, everybody knows about flippers. The best thing you might say about them is that they're not that difficult to make it immediate, and they're pretty inexpensive. They rarely fit well. And a lot of patients, especially people who are having a single tooth replaced, are like, why do I have this thing covering my whole mouth for just supporting this one tooth? The other thing to keep in mind is that these are mostly mucostatic, so they're beating on and trying to flatten out our tissue, when especially in the anterior, we're trying to get a nice papillary form. So this thing is definitely working against us. So a lot of offices have found that unilateral flexible partials can be a great option. And sometimes people don't think about those. If you have teeth on both sides of your implant, you can just make a nice one of these, and it's still mucostatic, but it's much more stable than a flipper. And it's small, so you don't get as much coverage. So that can be a really nice tool. I would say the Essex retainer is probably the other most popular. They look nice. They're not that obtrusive for the patient, but as you know, you got to tell them this is only for show, not for go. They don't get to chew on it. They can't wear it when they're sleeping. They need to wear it only in cosmetic situations. If it breaks, it really can't be repaired. It's got to be remade. Maryland bridges, they look nice. They're expensive as heck, and you need a little bit of room in this area. So if you have patients that want to spend the money and want to get a really nice aesthetic provisional, this can be great. You can do either a PFM like this, or you can do zirconia, as long as you're familiar and you know you have a good zirconia bonding protocol. You can also, this one has 2 wings as an aside. I was just hearing about a study the other day, study about how 1-wing ones tend to be more stable. So you can certainly do a 1-winger here as well. And then screw retained provisionals. I don't know why these haven't caught on more, because if I were a patient, I think this is what I would want. So what we can do is, you can only do these with a guided case, but if you make a guided case, in the lab, we can make a model based on the proposed implant position, and then we build a provisional based on that. We can contour the emergence profile however we want, so that we're shaping the tissue really nicely. And so then when the surgeon places the implant, usually you're doing these for singles, so you want to make sure that the clocking's just so in the guide. And then and then you can screw in the provisional. This has got to be way out of occlusion. It's got to be a 0.5 millimeter out of occlusion in any movement, because it'll make the implant fail if we put it in function. But for offices, there are a lot of offices that do these quite a bit. And I was talking to a surgeon up in Toronto that was saying that from the literature since 2014, this has been a viable solution. So I think it's one of those things that, especially if you're working in the anterior, especially if you're doing immediate restorations, this could be a really good way to both get your patient a nice tooth to wear during healing and to shape up the tissue. So think about that, I can say. So we've kind of talked about like getting the implant in there, doing the provisional. So now let's talk about, once the healing's done, what are we going to do? So there's a few tissue level implants out there. And for those of you who use them, you know that they really have nice health. The main challenge with them is they have no running room. So they have to be placed perfect. Perfect is okay with a tissue level implant. So that's the one challenge. But the vast majority of the implants that we're doing today are placed equicrustal or slightly subcrustal. So we got to create a channel, so to speak, through the tissue, and that's what the healing abutment is for. Like we talked about, most of the time now, people are doing this, which is single stage surgery, where once the implant's placed, a healing abutment's put on, the tissue is sutured around the healing abutment, and the patient didn't have to do another surgery. If we get a spinner or other health concerns, sometimes we'll go ahead and bury the implant with the cover screw and then do a secondary surgery. So for most of you that are on the restorative side, you'll be seeing the implants with the healing abutment on in any case. The custom healing abutment workflow would normally work best with a two-stage surgery. So that's something to keep in mind. So the first most important thing when you're restoring this implant, you have to know exactly what brand, line, and size has been placed. Understand the restorative workflows that are available, and making sure we have the correct components and instrumentation ahead of time. There are no generic components. An 050 driver is not a universal driver. I think we've all maybe done that when we shouldn't have, but let me see what this. Oh, that's not for me. Okay. There's a note. Sorry. But we want to make sure we have the correct drivers. We have, and especially for our impressions, we can't just take an impression of an implant. We have to have a component. And we'll talk about the 3 classes of components we can use, but we need to make sure that we order the right component, because otherwise, when the case goes to the laboratory, it doesn't really matter what the platform is on the implant. It only matters what the platform is on the impression taking component. So if those two are different, then when you get the crown or abutment, it's not going to fit. I like to always start with the surgical report. If restorative doctors ask me about this, I ask them to get the report from the surgeon, because a lot of times it has the sticker right from the implant vial that says all the vital statistics on the implant. Many times I have the serial number and the lot number. So if you have to call in for parts, you can tell the rep, that you're talking to on the phone, well, it's serial number blah, and then the pretty much guaranteed to get you the right parts. So that's really important. Every once in a while, if you can't get that information, your lab can help you identify implants from an X-ray. It's not the most predictable process in the world, but keep in mind that as a latch stitch effort, that can be a good way to go. So your first step when you're working with restorative cases, you're going to need to remove the healing abutment. This is a healing abutment. They aren't torqued, so you can just use your hand driver to remove them. Again, you're going to want to make sure you have the right driver for the type of implant that you're restoring. Really, the only complication that I've heard of with this is if this comes a little bit loose, tissue can grow in under here and prevent the components from seating. And if that's the case, it's not the end of the world. Either you or your surgeon will need to go in there with a laser or a scalpel and just clear that little bit of tissue out. If the patient feels a pinch, that's usually indicative that that's happened. And I mean, it's something I've only heard of a couple times, and I've been doing this for a long time. So I think I wouldn't really worry about it. I just, if your patient's going, ow, really double check your x-ray and make sure your components are fully seated. So then you got to decide what kind of impression taking components you're going to do. I'll start with analog, even though I like digital better. And this is the best analog technique. And this is what's called an open tray. So you can buy an open tray or a closed tray coping. And when you're getting your impression copings, keep in mind that many implant systems have different size healing abutments for the same implant. So you want to make sure that your impression coping is not only sized correctly for the platform of the implant, but it also has the correct size above that matches the healing abutment. So that way you can capture the tissue really nicely. Now, the reason this is the best analog method is because once these impression copings go into the impression, they never come out. If you look at the superstructure of these, you can see why. They have a ton of retention. If you tear them out, it destroys the impression. So there's no problems with reloading wrong or whatever. It just takes out a whole level of potential inaccuracy that we'll talk about on the next slide. So when you take the impression, what you got to do is, of course, pull the healing abutment, put the impression coping in, tighten it down, hand tight's fine, do an x-ray, make sure it's fully seated. And then when you seat the tray over the implant, you have to drill a little hole like this to make sure it seats well. So then you'll go ahead and take your impression like you normally would. It's nice to have a little cotton swab handy so you can kind of swab off the top of the screw heads here. Once the impression control sets up, you'll want to unscrew these long screws through the impression. And I recommend taking them out and putting them in a little box, because there's nothing more irritating than you got it 90% of the way, you go to pull the impression, doesn't come out, and you're still tight. So plus you got to send them all to the lab. So take them out one by one. Sometimes you got to use hemostats because they're a little bit tight, and then put them in a box so you can send them to the lab. Take the impression out, have a look at it, and send it to your laboratory. And then what we'll do is we'll screw the analogs on here just like this, the correct analogs that match that platform, and then make our soft tissue in our model. The beauty of this is that once you've taken this impression, this never moves. It doesn't move here. So it's always going to be in the same position that it was in the mouth. And we'll talk about, I mean, you guys, I think, know why that's important, but we'll talk about it a little bit more in a minute. So then you get your closed tray impressions. And these are more convenient. There's a few times where they won't work. If the implants diverge more than 15 degrees from each other or from the surrounding teeth, it's not going to work very well. This is kind of a modified technique with a little snappy cap that goes inside the impression. Usually the impression material goes straight to the impression coping here. But anyhow, when you go to take one of these, pull the healing abutment, seat this, take a radiograph, that's the same. And then when you take the impression, you'll just inject your impression material all around the mouth like you normally would, over this, around here. You want to make sure we pick this up well, because this is an important index we'll talk about later. And then once the impression sets up, you'll remove the impression, and then you need to take this part out and send it to your laboratory, the whole thing. Your laboratory cannot make a model without this. They have to have this part. Very important. One thing you can do to help your laboratory, since I'm a technician, I'm going to advocate for the laboratories here. If you have multiple cases, like let's say you're doing 13 and 14, if you put one little box that says 13, one that's labeled 14, even if they're the same part, sometimes they have some slight variances, and that way we'll make sure we get a nice, good seat. Don't put these back in the impression, by the way, because a laboratory will have to take them out again. And what makes this potentially inaccurate is this: pull the impression off, put it back in, take it off, put it in. Every time you're doing wear and tear on the impression, and you can't see for sure that this is perfectly seated all the way down here. Most of the time these work fine, but there's just a level of potential inaccuracy that's not my favorite. Now, I know there's going to be times where the patient can't open enough, or you need to use these components, so be it. And most of us laboratories realize how important this is, and there's like 1 or 2 people in the building who do this, so that we don't get just any old person sticking parts in the impression. This is one of those steps that's really, really important. But you can see that this process is intrinsically less accurate than open tray. Well, what if you had something that was like both? And that's like your intraoral scanner. So the first thing that's different about an iOS case is that you're going to use a component called a scan body rather than an impression coping. And you can see on this one, this is kind of a nice one here, how it has a peak surface up here so that it's easier to scan, a nice metal interface that fits in really tight with the platform to get a nice registration. These are specific also, they're not universal. So it has to match the platform that you're scanning. One nice thing about it is you don't need different tissue sizes, because what you'll usually do is remove the healing abutment, the healing abutment, and then the first scan you do will be of the tissue site. So you're capturing the tissue with your iOS, not with the body of the scan body itself. When you do one of these, do your lab a favor and note what brand of scan body you're using in addition to all the information. So you need 4 pieces of information. You need the implant brand, implant line, implant size, at least of the platform, and then you also need which kind of scan body you used on it, because the workflows in the laboratory are a little bit different based on scan bodies. Another thing to keep in mind is that if you look at this, any analog that will fit on here, I can use. So it's a fairly, you might say, open workflow. With scan bodies, there are workflows associated with them, like different kinds of abutments I can make and stuff like that. Now, you can make a model and then scan it, but you're taking out some of the accuracy that's intrinsic in the digital process by making models. So this is something that's nice to have a conversation with your laboratory about. Different labs like different workflows, and kind of talk to them about, hey, what scan bodies work best for you? So you guys can kind of help each other get the best result. But the cool thing about an iOS is that when you take a scan with one of these scan bodies, you're getting the accuracy of an open tray and the convenience of a closed tray. One other thing to keep in mind is that I'm sure all of you run into situations where you had an impression coping and it crashed into the adjacent tooth, and you know you got to have a little bit of space to make sure it's fully seated. So you can just reduce it a little bit with a carbide. Do not grind on. If you grind on the scan body, throw it away, because the way it works is that in the laboratory we have a file that this was manufactured from, basically, and we match it up. I got a little image of it. I'll show you in a minute. But if this gets altered at all, then your scan isn't accurate anymore. So no grinding on the scan bodies. So if you think about what we're going to try to do, either the analog in the model or the digital analog in the plan has to be in the exact same position and rotation as the implant in the mouth. Essentially, all the work that you've done so far is to register that information. So the only way that's going to work is if you have the correct part and it is fully seated. So if you see something like this, this is guaranteed to make a problem in the mouth. And usually what you'll see in these situations is that the crown is either badly rotated or way out of occlusion, or both. You always want to take a radiograph of the impression component in place. We can't see the interface, and we need to know for sure it's seated. This is an old school external hex, so it's pretty easy to see that it's seated well, like this one, or not like this one. The newer, I'll show you a film of a newer internal hex, are a little bit more difficult, so you need to make sure you get a really nice x-ray on those. So that's probably the biggest problem we see in implants in the laboratory. Component interferences we talked about. If the impression copings hit the adjacent teeth, it prevents them from fully seating, and then the analog in the model that we're building the stuff to is off angle relative to the real implant, and then you just won't get a very good fit. And then, of course, wrong components, we don't see that very often, but every once in a while you get manufacturers where the platforms are different, but the screw is the same. So you can screw a part, like let's say you could screw a 4 or 5 part into a 5/7 implant. Well, not only will the hex be wrong, but the timing will be wrong as well. So the lab will make a 4 or 5 and then it doesn't fit. And you're like, well, what's going on here? So again, really making sure you get those right impression components, use them well. The time that you spend at the front end here makes the seat go so much better. The other thing I would say is that, implant cases tend to have obviously missing teeth. And in cases like this, when we're doing physical models, we tend to have more problems with getting a nice solid bite. So this can be a good trick. And I like open trays, but on this particular kind of case, you maybe would use a closed tray coping, because what you can do is seat the closed tray copings in the mouth and do this, basically. Take a bite over them, then take your impressions. So that way you're sending these components to us in the laboratory anyhow. We'll do this. We'll make the model. We'll put the components on the model, and it gives it a really nice, stable bite. If you can't do this on a case and it's a free end, or you look at it, you're like, I don't know if I could articulate this well, you might want to have a bite block made from just a pre-treatment alginate or a quick IOS. So that way you have something to stabilize the bite. It seems like we see more challenges with bites with implant cases than otherwise. So, and as you know, the occlusion on the implant crown is so important because there's no periodontal ligaments to help us out. Now, another solution to this is to take an IOS, because when you scan this, as you know, the software captures this registration perfectly as long as you scan both sides of the arch. So this is another example where an IOS makes life better for you. Now, you're not going to be doing implants too long before you run into authentic parts. So what I would say, my definition of authentic parts, I would say is this. Every major implant manufacturer has an end-to-end solution for their implants. So they're not just wanting this to make the implant, but they make the healing abutment, the scan body, the pressure coping, the analog, and the final abutment. If we use all those parts together, that's an authentic restoration. And most implant manufacturers offer a lifetime warranty on implants restored with authentic parts. Now, that may not be the most cost-effective way to restore a case. And so sometimes people want to use other parts. Sometimes labs make their own parts. And sometimes manufacturers don't help us out any by being a little bit unclear. Probably the most popular non-OEM kind of abutment is an Atlantis abutment. Atlantis abutments are OEM for any kind of Dentsply implant, but they're third party for everyone else. Straumann's, I think, is especially fun. So Straumann owns Medinica and Neodent. Medinica is the OEM part for Neodent implant, but it's considered third party for Straumann, who owns them. So I guess what I would say about this is just know what you're getting yourself into. Make sure you have a good conversation with your laboratory about, these are the kind of parts I want to use. What do you see? And make sure that you have clear communication about that, so you're getting what you want. So you've done all this work. You've taken the registration. What are we going to do with it? So we're going to go ahead and make a model or a cast. And again, our goal is to get an exact representation of the patient's mouth, which we'll use to make a good restoration, which hopefully goes perfect on the day of delivery. So with physical impressions, we'll find an analog that is the correct platform. We'll affix it to the impression coping. If it's an open tray, we'll very, very carefully under magnification, put it back into the impression, make sure it seats all the way. And then we'll make a soft tissue model and pour it and get something like this here. I wanted to do the iOS second because this is kind of an interesting thing. See this gray thing that's floating in space? This is the representation of the scan body that's in our software. So when we know what the right scan body is, we select it. And then what we do is we mark common points, and then the software does like iterative matching, so that way eventually this is in the same position as this. And then this part locates the digital analog. So it's kind of similar to the analog process, but of course it's all done in digital space. So again, in the lab, we need to use the right parts too. That's an important thing. The other thing I wanted to talk about was pricing. And labs, implants are an area where us labs vary greatly. And so when you're trying to decide about pricing from laboratories, make sure you understand what you're buying. Sometimes the lab might have a price and you're like, ooh, that sounds pretty good. But you don't realize it doesn't include a soft tissue model. It doesn't include an analog. Maybe it doesn't even include an abutment, who knows, or a crown. So think about all the things that you need. And sometimes what's nice is if you're trying to kind of compare, ask the laboratories that you're considering if they'll generate a dummy invoice for, tell them I want to do a number 14 implant, send me a dummy invoice. And then that way you can kind of tell what your total pricing is. Sometimes the pricing on the price list can be a little bit misleading, just saying. So we got our model made. What do we got to do next? We're going to talk a little bit about restorative materials in a minute, but we got to decide whether we're going to use engaging or non-engaging components. So one of the fundamentals, as you guys know, of implant dentistry is that the final restoration cannot move once it's delivered. If it has micro movement, best case scenario, it leads to crustal bone loss and screw loosening. Worst case scenario, it damages the implant. We get to trephine it and put another one in. So it's really, really important that the implant not move. So if we're doing a single restoration, which is either like a single tooth screw retained or let's say a 3-unit cement retained bridge, we'll want to use these engaging components. Whatever the shape is, the geometric shape that's in the platform, a square, a hex, flower, then we want to make sure that this part perfectly engages. The engagement between the abutment finally and the implant is what makes the case stable long-term or not. All the screw does, and we'll talk about this in a minute, is holds the two parts together. So we'll want to use an engaging part for any of those situations. Really, the only time where you're going to use a non-engaging part is for multi-unit cases. And some of the newer well, they're not newer anymore, but in this century at least, studies have talked about how having one, like let's say you've got 3 implants you're joining together under a crown and bridge case. Historically, we would have done 3 non-engaging parts. Some of the finite element analysis, again, studies that have been done show that having an engaging component on the first one, on the most anterior, and then non-engaging on the other 2, gives even more optimal stability. So that's something that you can consider in your practice. Keep in mind that some restorative components can only be purchased as non-engaging, including the parts that interface with many multi-unit abutments. All right, so once we got the model work done, we can finally look at the case and figure out, hey, can we do what's on the prescription, or are there some issues we need to talk about? So let's kind of go through some of these. Limited interocclusal space is especially problematic with cement retained crowns. We want to make sure that we have a tall enough abutment so that we have good ferrule and stability so that your cement doesn't come loose. You're not seeing the patient every 3 weeks. That's not super awesome. So we need to make sure we deal with that. Sometimes your lab will call and say, hey, we need to switch this to a screw retained. And one thing to keep in mind, if cases are really, really short, you may need to go to a metal-based screw retained. Not every lab does this anymore, but if you do like a gold crown or PFM, you can buy a component that is metal on the interface and plastic on the top called the UCLA abutment, and then you wax up the crown or the coping part and cast it. So that way the crown is literally bonded to the interface. A lot of the screw retained crowns that we do as zirconian stuff have they have a cemented interface that we cement in lab, but nonetheless, they're 2 pieces and that can come loose from time to time, but those can't. So if you have really, really limited vertical, that could be a good option. What I mean by suboptimal implant position is that if our implant's off a little bit from a restorative perspective, we're going to need to do something to deal with that. The anterior crown here is a good example of, it's got a nice position for screw retain, but in order to avoid a black triangle at the buccal, we had to build this bridge lap so that way the emergence looks the same as the adjacent teeth. This is going to be a hygiene issue, and your lab will probably call you to talk about it, make sure that you're good with it and that you talk to your patient, and that's a thing we can deal with. Sometimes you'll see this too in contact areas where you have a large crown, let's say like a lower molar with a 4mm implant under it. You might have to have kind of ridge laps right at the crest of the ridge. so you don't have big dark triangles that get food stuck in them and stuff like that. For us laboratories, the worst possible position is an implant that's placed buccal and angled buccal, especially in the anterior. This point has to be in a given spot for cosmetics. If the implant is here, it's very difficult to get a good result. Those are going to be the most difficult to restore. So every once in a while, you're going to get one of those situations, and you and the lab will just have to work together and figure out, okay, what is feasible? And, you know, depending on where the patient's at, you may want to do a mock-up of what you can do, like a plastic provisional or something like that, just so everybody understands what can be done with the case. I know it puts you in a difficult situation because you're kind of caught between the surgeon and the patient. But I know you guys have to deal with that every day. So just kind of be looking at that. If you're seeing implants that look way buccal, you're going to want to talk to the patient about that early so that they don't, on the day of delivery, they're not like, why does my crown look so big and bulky? So, you know, make sure you work that through. Last but not least, we want to talk about pink porcelain. So this case, believe it or not, this is pretty good execution. And it was actually put in a magazine because it was pretty good execution. But even still, if this person had a high smile, you'd see that. It'd stand out like a sore thumb. So pink porcelain, the more you use, the better it looks. So like a full arch of pink porcelain with a good transition line, like a zirconia all-on-X or something, that can look really nice. Usually single teeth like these don't look as awesome. So from a clinician's perspective, it's really important to under-promise and over-deliver with your patients if you guys decide to do this. And you may also decide that you want to do more of a neck form on, but every once in a while I run into offices that haven't done a lot of these and feel like, oh, pink porcelain is a magic fix-all, and it usually isn't. So just keep that in mind, that it can be good, but it rarely looks just like gingival. Screw retained, cement retained, and screw inable. Most of you are going to have heard this before, but one of the things that's weird for new technicians is when you tell them it's a cement retained crown, they're like, what do you mean? There's a screw. It's like, yeah, with one exception that I know of, every implant has threads in it, and something is going to thread into those threads. So the question is, what holds the crown? Does the screw go through the crown, or does the screw go through the abutment and then the crown is held by cement? So that's how you tell a cement retained from a screw retained. Now, cement retained, I'm sure you guys have all heard this, retained cement in the sulcus, and this would be a really bad offender here with this narrow margin, is one of the leading causes of peri-implantitis. So we want to avoid that. And there's two ways to avoid it. One is to not do cement retained crowns. The other is to make sure that your laboratory designs your custom abutments with a nice margin that follows the, especially in the proximals and the lingual, follows the gingival contour and is just a little bit sub-G maybe on the buccal, so that you can clean it up quite easily. Also making sure that you use a radiopaque cement and that you use enough cement, but not too much. And I know that's like easy for me to say, but you get a feel for it as you do so. The nice thing about cement retains is that they're really easy to deliver, in the sense that you can torque the abutment, take a radiograph, make sure it's seated, and then this just becomes a metal prep, adjust the contacts, cement it, and clean it up. So that's really nice. Screw retains, there's no cement, or the cement has been cleaned off long before you get it. So it's definitely much more favorable from a implant health perspective, but the contacts affect the fit. So it becomes a little more challenging to adjust the contacts. So you want to get really good contacts, but you also have to make sure this is seated all the way. This is a place if your lab, you can say, hey, you guys, put a little extra time in those contacts on the screw retain, because those really, really make a big difference for you, as you know. So sometimes the perfect solution is what you'd call a screw mentable crown, for those of you maybe who haven't heard of that before. And that's something where we make a full-size abutment, we make a normal crown, and then we put a hole through the crown. So when you deliver it, you hand tighten this, do your x-ray, seat the crown, cement it. But then it has a hole through the occlusion. So you can just unscrew that whole assembly and easily clean up the whole sulcus, get it looking nice, and then torque the crown to place with the abutment. You know, it's all one piece at that point, and fill the hole with your PTFE and composite like you normally would. All this, of course, is assuming that the implant's placed so that the screw hole can come out through the occlusion or through the lingual. As you know, angled screw channel type or angled screw access, or everybody else's term for it, is becoming more and more prevalent. So that can be a solution, but we want to keep in mind that it's not available with all systems. So you want to kind of think about that when you're choosing your implant system. And also, it usually requires a different driver. So you want to make sure you have the right driver for that. Restorative concerns, splinting. So this is kind of asking a favor that we shouldn't need. It's kind of a convention at dental laboratories that if we see 13-14, that means a splint, as opposed to 13-14 means 2 crowns. Now, we should know that splints are not good, that they're very bad for hygiene. Of course, you guys are trying to avoid them as much as you possibly can. But some of our folks aren't as familiar with those things. And so one of the things that you can do to help your laboratory is kind of use that numbering convention. If you have 13, 14, and 15 implants, if you put commas between, that helps us out. So that's nice. Again, we talked about cantilevers and ridge laps, that we're usually going to be doing those only in situations where we need to seal up dark triangles or make aesthetic improvements. And then dark triangles and emergence profile. A lot of times we can kind of do a trick where we over contour the lingual, so we still get a nice buccal contour and these triangles aren't as bad. Sometimes we can use pink porcelain, but again, pink porcelain can look really weird here. Can look like there's a chunk of pink goo stuck to their tooth. So, and obviously this is a case where if we do a nice custom healing abutment and shape up that tissue, then all we got to do is hold it with the crown. We're not trying to make it restoratively, which can be an important thing too. 3 kinds of abutments: stock abutments, custom abutments, tie bases. Back in the day in laboratories, we used to see a lot more stock abutments, which were, you'd buy them from the implant manufacturer, you kind of pick the total height and the tissue height you wanted, and then make a cement retained crown on it. A lot of times you'd have to prep it a little bit in the mouth. Like this, it's rarely optimal for the patient or for tissue. And then in this case, with what we know about cement in the sulcus, you can see this is not going to be an awesome situation. Now, used to be that these were more affordable, but it's gotten to where most labs, you're paying the same price for both of these. And so I would say you're always going to get a better result with a custom abutment because you get nice tissue forming, you get a better emergence. You can see that this case, this case is going to have much smaller dark triangles than this one. And then the other abutment that I wanted to talk about is a tie base. With so many crowns being zirconia these days, zirconia is very, very strong, as you know, and it really doesn't need to be reinforced by the abutment. It's strong enough to kind of live on its own. So these days, when we make a screw retained zirconia, if we're going to have a metal interface, we use a thing that's called the tie base. And basically what this is a perfect interface with just a little ridged piece like this inside of it that we can cement the crown to. These are, I mean, they're fine, they work well. And I think you're seeing more and more of them since most of us are going to more screw retained and more zirconia. Custom abutment design. This is something you'll probably kind of want to talk to your laboratory about. One of the cool things about doing a custom abutment is that we can scan the tissue on our lab scanner, or use your scan if you did an iOS, and then we can kind of decide how the abutment interacts with the tissue. And we can even decide in different regions. So like down here, we can say, you know what, I don't want any tissue pressure here. But we can say, you know what, up here, I think I would like to put a little bit of pressure to help with, to get a better emergence profile. See how nice this is going to be? This crown is going to have a beautiful mesial contact on it, I think. So So this is something we can, in the laboratory, we can kind of decide how we want this. And so if you have a preference, then please be sure and share it with your laboratory. Every once in a while, you're going to get a case where we need to really, really move the tissue. And so something that you can do is we can contour, kind of like we would with a custom healing abutment. We can contour the abutment exactly how it ought to be. And then it's not going to seep when you just set it in the mouth. So what you'll need to do is take a scalpel and make a couple of incisions like this all the way down to the bone to basically release the buccal and palatal tissue from each other so that they can adapt to the new abutment. And so we use the abutment to form the tissue. The people I know who do this have said that you usually don't have to suture these. They'll heal up quite nicely on their own. So this is a technique you can kind of keep in mind, especially if you're looking at a situation where you're going to have huge dark triangles or something like that. This can be a good fix for it. Basically, we have two kinds of abutments we can use, titanium and zirconia. Titanium has been around for a long, long time. Great material. Obviously, as everybody knows, very biocompatible, lightweight, super strong. Really, the only thing that's bad about it is it's gray. And so if you have really thin buccal tissue, sometimes it can discolor the buccal tissue. Now, you can ask your surgeon to help you out with that by doing some grafting when the implant's being placed. So that can be something to keep in mind. But let's say for whatever reason it wasn't done or didn't work or whatever. And the other thing is sometimes when we're doing anterior units, especially if we're doing a more cosmetic material like a lithium silicate or a lithium disilicate, this might show through and lower the value a little bit. So some manufacturers and some laboratories will anodize the abutment with a gold like this. It really helps cut down on the graying both through translucent restorations and also through the tissue. And some of those tissue, getting the tissue to stick to the abutment treatments that we were talking about earlier are basically an anodization process that happens to make it gold as well. So you'll probably see more and more of this. It is an electroplating process that's done after the abutment is milled. Probably the nicest thing about titanium is it's a metal. So as you know, metal is malleable and tough, and it's going to give before it breaks. Zirconia, on the other hand, as you know, is very, very biologically friendly, perhaps even better than titanium. And it looks pretty with thin tissue, obviously a lighter one like this. These days, you can even get these in 2-shade. So it would really look nice on a thin buccal or maybe in a lateral, something like that, where you need really, really nice aesthetics. Many of these, though, come with a zirconia interface down here. And with those components, every once in a while, these will break. If this breaks, it's a nightmare. The good news is you get to remake the whole thing, which doesn't sound that good. The bad news is once you get the screw out, you got to fish all these little fragments of interface out of the implant. And if you don't get them all out, then it's going to keep all your other parts from seeing. They're a real pain in the behind. Most of us labs have been bit a time or two on this, and we're not as keen on these. But I would say there's more and more manufacturers who are coming out with a titanium interface on a zirconia abutment. And that can be a really, really nice option for your cosmetic cases. So what kind of materials can we make implant crowns out of? One of the things I try to keep in mind, and I mean, it doesn't matter as much anymore since Ivoclar discontinued Empress, but these crowns are going to have more load on them than a natural tooth in the same position because, again, there's no shock absorbing from the periodontal ligament. So when you're kind of thinking about a case, you're thinking about how strong you would want it to be for a tooth-supported case. You might want to go up like a half a step with your implant cases just because of the extra load. Zirconia, obviously most popular. I think the monolithics are getting nicer and nicer in terms of shade, so we see lots of those. If you're doing a case that, let's say you got one implant crown in the middle of a bunch of lithium disilicate veneers, sometimes doing a veneering porcelain on the buccal will make the case look a little bit nicer and help with that blend, because sometimes getting the value right between a zirconia and lithium disilicate with more translucency is just can be a little bit challenging. So that's something to think about. PFM and gold crowns, we talked about it before. This is what a UCLA abutment looks like. You stick wax onto this part and then cast it. There's little threads in here, so the cast metal goes over the threads and it essentially becomes one piece. Again, there have all the pluses and minuses of a tooth-borne. They're really good for super short situations in the posterior, especially in the mandibular posterior, where you got a lot of load, but you're probably not going to do a lot of those. Emaxes, great solution for implants. I know some people do them for screw retained. I tend to like the zirconia myself a little better for screw retained, but if I'm doing cement retained, I'll get a nice result with Emax. So those are kind of I think your go-to materials for your crown and bridge cases. So now it's time to deliver your abutment in your crown. So first, of course, you're going to remove the provisional and the healing abutment, and again, check for tissue over. When you see the abutment, again, you want to make sure the patient doesn't have any pain. And this is something that I think most of you know, but I want to mention it. A person shouldn't be able to feel anything through their dental implant. If they're actually feeling pain in the implant, that probably means the implant's failing. So I would discontinue whatever prosthetic treatments I'm doing at that point. Go ahead and get them into the surgeon and get that case reviewed. There's probably some not so awesome things going on. For your cement retained cases, there's oftentimes a mark on the buccal that shows which direction to orient it. If you're not sure, it's nice to put it on the model before you see the patient and make sure you understand the orientation. Sometimes with molar ones, it's kind of hard to tell which side's the buccal or the lingual, and you want to make sure you got that all nailed down before you start on the case. Every once in a while, you're going to be like, why won't this thing seat? And it could be that there's a little too much tissue pressure. Usually you can tell because it'll hurt, and also you'll see some real pronounced blanching. And there's a couple things that can happen here. One is you can do some anesthesia and kind of tighten it, let it set, tighten it. It'll kind of work its way in. Sometimes you're going to need to have it recontoured a little bit or do release incisions. And it kind of depends on the implant system. Some implant systems are designed so that the fixation screw won't grab until the anti-rotational components in the platform are engaged. Some are not that way. And so you can start tightening the screw and the abutment will pull down, and instead of engaging, let's say, the hex, it's sitting on top. So now your abutment's up about 1.5 millimeters, kind of like, which is not good. So you want to make sure that when you're seating your abutment, sometimes you give it a little wiggle woggle and you'll feel about 1 millimeter of drop. And then you know, okay, that's engaged, tighten it up. And then of course, you'll want to, like we talked about, take an x-ray, make sure it's down. Once you get the abutment down, of course, you'll, if it's screw retained, you'll fill a hole. And if it's cement retained, we already talked about that, so I'm not going to belabor that point. Sometimes your labs will provide you with a screw that's never been used before. You'll want to make sure you use that to the appropriate torque to deliver when you're ready to deliver the final restoration. One other little trick I would say is that, let's say you get an abutment that fits well, and for whatever reason, you just cannot get the crown down. Sometimes the best way to deal with that is to put some retraction cord here and just take an impression of the abutment. Because, the definition of insanity. We tried to take an impression with an impression coping or scan by or whatever. It didn't work so hot the first time. So we can just double check our occlusal clearance. The other advantage of doing that is that you can make a provisional on that, and at least the patient's going home with a tooth, not the final tooth. It's not ideal, but at least it gets you further along. So that can be a little trick. Hopefully you never have to use it, but good to know. Again, take an x-ray. This is what I was talking about with an internal connection implant on the left here. See how on the right-hand side, you can see there's a big old gap. That thing isn't seated. But sometimes you'll see kind of an angle inside here. It's a little bit harder to tell. So it becomes really important to take your x-ray so that the platform is flat. So that way you're really seeing right in there. The better the angle on your x-ray, the easier it is to see. If the abutment isn't seated all the way, you're getting that micro movement, which doesn't do anybody any favors. But let's talk about the last component of getting everything to fit together, which is torquing your fixation screw. So torque is a measurement of resistance to rotational force. So what happens is that when we torque the screw, we're basically stretching it like a spring. So the equal and opposite reaction is that it clamps the abutment to the implant. Now, it does not prevent the components from rotating. All it does is it makes the abutment interface fit into the implant platform. So however well or poorly that fits is however much or little movement you're going to get. So you'll see a lot of implant companies that do Morse tapers and stuff like that to make that more favorable. So a few little caveats about screws and stuff like that. So whether you use a OEM or a third-party manufacturer, usually the screw head on the screw is the same. So if you need a star-shaped driver based on the implant, it'll still use a star-shaped driver. But oftentimes the middle of the screw, the threads are the same, the head's the same, but the shaft that connects the two can be different. And so you have to, if you need to replace a screw for whatever reason, you need to know who the abutment manufacturer was so that that way you can have the correct screw that will actually fit in that abutment. So a good thing to keep in mind in terms of your charting and the like. Again, if you're using an angled screw access, it's going to use a different driver. So make sure you have that driver ahead of time. And the third thing, which is a little bit of good news, is a torque wrench is an instrument to apply rotational force. So if you can get the correct tip that will fit in your driver, you can use one torque wrench with a variety of different implant systems because these are not free. So as you know, so that helps a little bit. So once you've got your screw retained crown in, all you got to do is torque it, fill the screw access hole with your PTFE and composite, and you're done. But if the crown's cement retained, you got to figure out a way to get that cleaned up because this is what happens if not. This is an implant that was lost due to peri-implantitis, and you can see all that cement in there. That's the problem. So we really got to make sure we get that cement cleaned up good. Again, I think the screw metal bowls can be a good solution for that. So kind of add that to your toolbox. So potential complications at seating. One of the things we talked about is that rotation or occlusal problems. If the impression coping wasn't seated all the way or the scan body, usually how that looks is that the crown seems like it's like turned a certain amount or it's way out of occlusion. Unless it's an open tray, a closed tray impression, the laboratory didn't load it properly, most likely that's a records capture problem. In any case, if you get that, you're going to need to take another impression or scan. Again, that's why I like open tray impressions better because loading is not a variable. There's no loading or unloading or anything else. The other thing is every once in a while you'll see this where it doesn't fit. And again, this is a screw retain, so you need to take a new impression. But at times you'll have situations where you have an abutment. And if you have an abutment, again, my thought would be torque the abutment, take an impression or a scan of the abutment like a prep, and then provisionalize it. So that's that. That's my little segment on the crown and bridging part. So what I'm going to go over all on X just really briefly. Interestingly, this is that gold anodized thing I was telling you about that is designed to create better tissue attachment to the abutment and hopefully create better implant health. So who are we usually seeing? What we're going to talk about is like the oldest way to do this, which is freehand surgery and a freehand conversion and a hybrid. There are so many different cool new workflows, but at least this kind of gives you an idea what's going on. And when you have a patient who comes in who would like to do this, you can work with obviously us or your lab or your surgeon to kind of plan out what's going to be best for this person. Statistically, the average person who comes in for this treatment has 6 to 8 failing teeth per arch. It's rare to find, it's less common to find edentulous people. So because their primary concern is that they're afraid they're going to have to live without the teeth, this whole process is geared towards getting them in teeth on the day of surgery and keeping them in teeth. So when you're treatment planning, if at all possible, you want to make sure you've got a plan to get a non-denture provisional in there on the day of surgery. So, this is sometimes called teeth in a day, and I guess technically that's true, but there's a lot of days before that day, and there's a lot of days after that day where dentistry needs to be done. Of course, for a freehand conversion, you'll need an immediate denture, so you need to take records with nice borders for your laboratory. Take a bite at where you want the person to be. Your laboratory will cut the teeth off the model, set denture teeth or design them, and process or print a base and send you an immediate denture. A lot of times as well, the laboratory can duplicate that denture in clear and then cut a slot like this that's behind the incisal edges of the anterior teeth as kind of a guide to the surgeon. If you can get implants in this zone, we can get a nice result for this patient. So the surgeon reflects the tissue, extracts the teeth, does the alveoplasty, places the implants, places MUA abutments, and then sutures. And then usually temp cylinders are put on the MUA abutments, holes are punched in the denture is connected up to those temp cylinders, and all the flanges and stuff are cut off, and that becomes the screw retained provisional the patient wears. Again, there's a lot of ways that are a lot easier than that. If any of you have ever done that before, it's a project. So, but anyhow, that's kind of what happens overview on the day of surgery. And then, so 2 to 4 months later, patient's all healed up. What are kind of your clinical appointments restoratively? Again, a lot of digital processes that can make this easier, but the old school method is you take an open tray impression of all the MUAs, and then you'd get a screw retained bite block, just like you'd have for a denture, except it has a couple screws in it that you screw to the MUA, do your normal bite block thing. You also get a thing called a verification jig, which is a temp cylinder for each site, oftentimes glued together with plastic. And what you want to do is screw them all down and then unscrew all but one and make sure that it fits perfectly. What it's for is to make sure that the model and the mouth are exactly the same. If it's not fitting stably, you need to figure out where it's loose, cut it, and relute it together. If it's one implant, I'd usually recommend cut it. If it's 2 implants, I'd recommend retaking the impression. But if that all looks good, next appointment will be a setup, and it'll just be that same screw routine base plate with some teeth set on it. You want to check that pretty closely because that's going to be the template for the final restoration. And then in the laboratory, we'll make a bar, and most of the time we'll transfer those denture teeth onto the bar, and you'll do one more setup trying. And that one you want to really be picky because that's exactly what we're going to try and copy in terms of adaptation of the tissue, emergence, thickness, speech, bite, et cetera, et cetera, et cetera. A good tip is always take a bite over these when you're doing your try-ins. It just gives an opportunity to perfect that bite one more time before we do the final restoration, and then process and delivery. So that's kind of the workflow. Again, a lot to that, but at least it gives you an idea of it.